of Psychiatry Grand Rounds. This morning we welcome Dr. Judy Rice, who is an assistant professor in the ETSU College of Nursing. She's also the interim director of graduate programs here at ETSU. She's been a nurse for more than 20 years. She completed her master's, her BSN and master's in nursing here at ETSU and has a doctorate of nursing from UT Science Center. She's also taught here at ETSU since 1996, where she's won the annual teaching award as well. She's been involved in care of the homeless here in our community. She also has several publications and topics ranging from dissociative disorders to pediatric behavioral health disorders. She's given many community, national, and international presentations on mental health care, and today she's here to talk to us about the Johnson City Community Health Center and caring for the uninsured mentally ill. Thank you.
Hey, thank you. Can everybody hear me okay? Okay, well, I'm so thrilled to be with you all here this morning. Happy Friday to everyone. I love to talk about our clinic. I've worked as a psychiatric nurse for 24 years. Guess that gives you an idea of how old I am. But I have worked inpatient, and then I came to ETSU. And when I started at ETSU, I started at one of our nurse-managed clinics from the homeless. So I'll be telling you about that later on in the presentation. And I think I have the best job in the world. I get to teach students about clients that are experiencing mental illness, and I get to treat homeless clients, which is my favorite population. So I'm very lucky, very blessed that I have the job I have, and I encourage all of you that are students to pick the area of medicine that you're passionate about, and you'll never have to work a day in your life. So I have no disclosure of financial interest. And today, what we're going to talk about just very briefly is the incidence and prevalence of uninsured clients with mental illness, some of the problems that occur when clients don't have insurance, but they do have a mental illness. We will discuss some evidence-based guidelines for treatment of clients with, that aren't insured. And then lastly, we'll talk about the model of care that we use at our clinic. So these are statistics you all are, I'm sure, very aware of. Psychiatric disorders are so common. 1 in 5 of us have a psychiatric disorder. Some resources say it's actually 1 in 4. And one thing why it's so important to provide adequate care to clients with a psychiatric disorder is because if it's untreated, they're going to die earlier than the general population. Having a serious mental illness shortens your lifespan by as many as 32 years. And we have a lot of lost days of productivity in our country due to psychiatric disorders. And it's a very disabling disease. It accounts for 1/3 of adult disability globally. This is from a SAMHSA survey, national survey they did in 2014. And they found that only 38% of individuals with a mental health issue received any treatment at all. And they estimate there's 10.7 million Americans that have an unmet need for mental health treatment. And this is what I think is a key number to remember, and I always tell my nursing students this, is 2/3 of all people with a diagnosable psychiatric disorder do not seek treatment. And there's many reasons why that they don't seek treatment. So many reasons. These are patient-level factors, provider factors, systems-level factors, and we could talk about these all day long in another presentation, but in many of these you all are very well aware. But of course, stigma. Stigma certainly plays a role, and stigma is deeply rooted in our history. Back in prehistoric times, they took people who they thought had these crazy behaviors, and they decided to make a hole in their skull so the evil spirits would escape. And these are some of the devices that were used during that time. So going back in our history, we haven't treated these clients very well. And then looking also at provider level factors, there's work shortage, and there's a lot of fragmentation of services. And if you historically, a lot of this fragmentation of services and shortage of services began in the 1960s when we got rid of a lot of our institutions. And I think John F. Kennedy had a great idea that the care in these institutions was not very good. And so they were let out in the community. Unfortunately, the community wasn't very well prepared to meet the needs of all these large groups of patients that had been institutionalized, and they were now out in the community. So can anybody tell me where the largest inpatient psychiatric facility is in the United States? And let's not say psychiatric facility. Let's say, where is in the United States a building, a structure, an entity that houses more inpatient more people with psychiatric disorder than any other place? I saw your hand first. It's in the slides, right? It's not? Cook County Jail? Okay, all right. Well, studies have shown it's Los Angeles County Jail. But the bottom line is we de-institutionalized our clients, and now the de facto institution have become our jails. And since de-institutionalized, you know our clients are often in limbo. This is a quote for someone recently in the Wall Street Journal who said the severely mentally ill exist in limbo. They're neither institutionalized anymore, and they're not very well embedded into a community. And then let's talk about workplace shortage for a minute. The total number of physicians in the United States increased by 45% from 1995 to 2013. However, the total number of adult and child psychiatrists rose by only 12%. During that span, the U.S. population increased by 37%. That's just horrible, I think. And the Johnson City Press just, I think, 2 weeks ago in the Sunday edition talked about the lack of psychiatrists we have. And I'll talk a little bit more about that in a second. This one I think is unbelievable. 70 years ago, we had 600,000 inpatient psych beds. Today, double the population, there's only 65,000 psychiatric beds. That's just, but we have 9.6 million people with a mental illness. That is not good. The average time between a first episode of psychosis to when they're able to initiate treatment is 110 weeks. That's crazy. In the United States, talking again about the workplace shortage, 31,000 counties here in our country, a non-third world country, 31,000 counties have no practicing psychiatrist, psychiatric NPs, psychologists, or social workers. Another study reported that nearly every county in the United States, 96.2%, has unmet needs for prescribers in mental health. Another study said 55% of all counties don't have a practicing psychologist or social worker. The Mental Health Association of Maryland reported that this is from 2015, in the state of Maryland, only 14% of their psychiatrists listed in their health care plans were accepting new patients. Only 14% of psychiatrists. How do these clients get care? And it was beyond the average recommended wait time of 45 days. And they also reported that clients in Maryland, just like my clients here in Tennessee, are having a great difficult time paying for medications, and many times they're paying out of pocket. So let's go back and talk about the uninsured. Martin Luther King's, one of my favorite quotes, he said, of all the forms of inequality, injustice in healthcare is the most shocking and humane. And I see that every day in our work with our clients that don't have insurance. The U.S. Census has estimated that about 48% people in the United States are without insurance, and we know the benefits of insurance. Those who don't are less likely to receive preventative care. They're likely to have more undiagnosed chronic problems, and of course, poor health outcomes. You all know this. Of 30 million, this is another study that looked at 30 million Americans who were both indigent and uninsured, and 7.6 million of these clients will require some kind of mental health care in the course of a year. Adults with mental illness lack insurance coverage at significantly higher rates than those without mental illness. So having a mental illness really, in not having insurance can be very detrimental. More than 1 in 4 young adults aged 19 to 25 are uninsured. I'll talk a little bit about this in a minute, but that's when many of our psychiatric disorders present in this age, and then they don't have insurance. We know that clients that do have insurance are more likely to seek and receive mental health treatment than those who are uninsured. And we know approximately, some cite this number higher, that 4 million seriously mentally ill, not just mentally ill, but those with a serious mental illness in our country don't have any insurance at all. In another study, they looked at a 12-month period for almost 3/5 of persons with a serious mental illness did not receive any mental health care from a specialist, so they weren't seeing a psychiatrist or psychologist or a Psych NP. This study also pointed out that 1 in 5 persons with severe mental illness are uninsured, and that if clients have Medicaid, if they have Medicare, they're 6 times more likely to see a psychiatrist than those who do not. So these are just more statistics showing that people with mental illness often don't receive treatment. It kind of supports the slide I put up a few minutes ago, that 2/3 of clients that have a diagnosable disorder don't seek treatment. This is a study from the CDC, and they found, their exact quote was, the poor have more mental health problems than the rich. And they pointed out that their study looked at infants and toddlers that were growing up in toxic environments, such as having child abuse, seeing violence in the home, living in extreme poverty, that this can hinder brain development, and we know the brain is more neuroplastic the younger we are, so it's more vulnerable to traumatic events, and that can lead to mental illness in adulthood. Another study said low-income uninsured children and adults were substantially less likely to report mental health symptoms than low-income children and adults that did have Medicaid or Medicare. And so I mentioned a few slides ago, I talked about young adults, and there's a problem right now with a lot of young adults. Many low-income young adults become uninsured. They have Medicaid or TennCare, let's talk about Tennessee, when they're a child, and then they age out of the system. And this becomes a problem. And studies have found that up to 76% of all young adults who have aged out of Medicaid don't have any insurance at all. And again, this is a time, an age when, these are 18 to 25-year-olds. It's a high-risk age group for the initial presentation of psychiatric symptoms. So despite all these other problems, we know that our health insurance system, there is some discrimination, and it really affects those with mental illness. Historically, our insurance system has been based on employment. It's been employment-based. Well, many clients with mental illness are unable to work, so they can't access, or they're underemployed. I have clients that work harder. They work 15 hours a day, every day, 7 days a week, but they work in a place that doesn't offer them insurance. And health insurance often discriminates against specific population groups, historically African American and our Latino clients. And then individuals living in poverty are significantly less likely to have health insurance than individuals with greater household income. And that's common sense information. So then we have the Affordable Health Care Act, which works, to end some of this health insurance discrimination. And it is said when it's fully implemented in 2019, I guess depending on who becomes president, but if it becomes fully implemented, it will extend, according to President Obama, health insurance to nearly 4 million previously uninsured people with severe mental disorders. So these are states that shows the numbers of states that opted out of Medicaid expansion. The green states are states that opted out of Medicaid expansion. And you can see that there's a total of, I'll go back to this, 568,000 people uninsured people who are diagnosed with a psychiatric disorder, they would have been able to receive treatment if their state had chosen to expand Medicaid. So 568 people who are unable to access treatment now because they aren't able to get Medicaid. So that's a huge number. Let's talk quickly about some of the repercussions. What happens when we have clients with the mental illness that are uninsured? Well, first, there's all kinds of economic repercussions and repercussions to us even. There's a lot of lost productivity. Many studies say depression is the leading cause of sick days in our country. There's caregivers' lost earnings. The clients that have family members that care for them, they often have to take off work. One of the principals at my son's school, he's very vocal. I admire him so much because he talks about his wife having a mental illness. He's not afraid to say that. He often has to leave work several times during the day to go care for his wife. And then because our uninsured mentally ill, one of the places they might be ending up are in prisons. And they end up in jails and prisons, and it's not even a violent offense. My clients, they'll get picked up maybe for public intoxication or trespassing. They don't even know they're trespassing. They'll end up in jail. They get out. They can't pay probation, so they get put back in jail. It's just an endless cycle. So they end up being in jail. And it costs us a lot of money to pay for care in prisons. It's in New York City, to have someone in jail for a day, it costs taxpayers $60,000 a day. Still thinking about economic repercussions, a lot of clients that don't have insurance end up in emergency departments, which is very costly. The hospitals are then uncompensated for the care they provide to these clients, and that increases the burden on hospitals and also on taxpayers. Now, more importantly, let's look at the consequences to patients that don't have insurance. First off, they have unnecessary suffering. We all know there are effective treatments for mental health disorders. Clients without insurance, they're not getting treatment. They are suffering. It causes so much suffering, so much functional impairment. They could die. They can have significant economic losses. They could be living in poverty. I've seen people just like you and me that had a job, had a great job, had insurance. Their mental illness flared up. They weren't able to afford the treatment. It led to a vicious cycle. Next thing you know, they're without a job, they're homeless and living on the streets. Great deal of healthcare costs. Many people are having to pay for medications, even hospitalizations out of pocket. I had a client recently, not in this area, but another area. He tried to access an inpatient hospitalization, and they said you need $1,500 up front. This gentleman was homeless. He did not have $1,500 to pay up front. He went and asked friends, family members if they could start selling things so he could get the $1,500. He wanted to detox. He spent 24 hours selling things, begging, borrowing, not stealing, and finally was able to get into an inpatient facility. Without insurance, there's an increased risk of hospitalization, so that's not very cost effective. When you don't have your mental illness treated, obviously your physical disease have the likelihood of worsening. Some resort to violence, unfortunately, and that's sad. They've done studies on people with mental illness who commit violent acts. 80% of those they feel could be prevented if the client had been on medication. Not having insurance, not having treatment leads to a lot of self-medication. People will turn, I hear this all the time, I can't pay for my medication. They might be manic, I can't pay for medication. I'm going to drink, smoke pot, buy Valiums off the street just to get my mood down a little bit. Many clients, and I can't tell you how often this happens, they become homeless. Poor social functioning, they lose their social support. They often live in isolation. And it can ruin their life. It diminishes their quality of life. They're not able to work anymore. And I'd like to show you some pictures. Let me do this slide first, and I'll show you some pictures. But where might they end up? They might end up in jail, prison, people with clients with mental illness not insured. They end up on the streets. They can end up in homeless shelters, and then it can end up in the morgue, unfortunately. So I have some pictures of a client who doesn't have insurance, and I apologize, these pictures were taken off a poster, so they're not the best pictures in the world. But this is a client of mine. He let me take pictures of where he lives, and this room, he rents a room. It's filthy, it's nasty. It's in a boarding house downtown Johnson City. It cost him $495 to live in this room that's about the size of a typical walk-in closet. He has his bed here, his little stereo here. You can see the cans, how dirty it is here. These pictures are kind of hard to see, but you can see it's just filthy. He doesn't know how to care for himself very well because of his mental illness, and clients like him often have to live in very shady dwellings. So, what can we do for clients that don't have insurance? Let's first look at the evidence-based recommendations for uninsured clients with the mental illness, and then we'll go and talk about what we do at our clinic. So, one study I looked at explored the benefits of patient-centered medical homes. So this is something that frequently comes up in the literature as an excellent way to address, to get hold of clients that don't have insurance. In this particular study by Olson found that participants with a usual provider, so having the same provider all the time at a patient-centered home, were significantly more likely than those with no usual provider to have experienced a primary care mental health visit. So they were more likely, if they have a usual provider, to come back and get treatment for their mental illness. One study by Crowley he felt that mental and substance abuse disorders are estimated to surpass all physical disorders as far as the worldwide cause of disability by 2020. I think the World Health Organization says depression will be the second leading cause of disability in the year 2020. And so this research also called for patient-centered medical homes to effectively address mental illness. One thing that frequently comes up in the literature, it's recommended that patients be able to have access to primary health care and to mental health care under the same roof, which is what we do at our clinic. The World Health Organization has called for integrating mental health services into primary care. They think this is the best way to treat those that are uninsured and that have a mental illness. The mental health advocacy group, Mental Health America, they also believe that integrating mental health in primary care is something we all need to be doing. And current health care reform, even the Affordable Health Care Act, stresses the need for integration of mental health services into primary care. So we hear that a lot, the catchphrase integrated care. So what does it mean? And in the literature, it can mean several different things. It could simply mean the integration of care for Medicare, Medicaid, dually enrolled beneficiaries. It can mean we're integrating mental health and substance abuse together. And I'm sorry, I put that twice. I didn't catch that typo. But largely what it means is the integration of mental health and substance abuse into primary care. And then, are you all familiar with the Mental Health Reform Act 2015? This was proposed by 2 senators August 4th, and I've listed some of the essential components of this Reform Act. But the biggest thing, as far as what we're talking about today, is this act would require states to identify barriers to integration of mental health care into primary care. And they're offering states millions of dollars in grants for those who are willing to do that. So why primary care? Why should we be integrating mental health into primary care? Well, they're already doing it anyways. They've become, they're caring for clients. They're the default provider of clients with psychiatric health disorders. More clients with mental health issues go to primary care settings than they go to psychiatric facilities. At least 30% of all clients that are primary care patients also have a diagnosable psychiatric disorder. And they say that 1/3 of patients with a psychiatric disorder, all the health care they get is from a primary care setting. Also, we know, I've already mentioned this, that mental illness exacerbates physical illness. And stigma is important when we're talking about primary care. A lot of people prefer to go to a primary care setting because they're embarrassed and ashamed to go to a mental health setting. I have a client who recently got insurance, and I was going to refer him to Watauga Behavioral Health, and he said, "No way, I'm not going there." And I'm like, "Well, why?" And he said, I don't want people to see me in the parking lot. That's an open parking lot. I don't want to see people to see me walking in. I know a lot of people in the downtown area. So many clients prefer to go to a primary care setting just because of this stigma. And we know, the literature has shown this for many, many years, that people who commit suicide, they often show up in primary care settings before they do commit suicide. 45% of people who died by suicide had contact with their primary care providers in the month before their death. For older adults, the number is it's much higher. 78% of all older adults saw their primary care provider 1 month before the suicide. And then malpractice claims. Almost 15% of our malpractice claims are related to suicide. Studies have continually demonstrated that the provision of frontline mental health services in primary care settings does have positive impacts. Several studies have shown that it improves patient and provider satisfaction. It reduces healthcare cost. It improves clinical outcomes for our patients, and increases adherence to treatment, and it significantly reduces stigma. So, what are some models that are being used? We have the collaborative practice models are often referred to in the literature, and I've defined this on your slides. It's the continuous interaction of 2 or more professions or disciplines that are working together to care for clients with a mental illness. This has been well studied over the years, but it's underused. We are starting to see it used a lot more, especially even in this area. And studies have shown this is very helpful to the primary care physician. Many primary care physicians and nurse practitioners do not feel comfortable treating clients with a mental illness. By having a collaborative practice model, a social worker, a psychologist might be placed within the primary care clinic, and they will provide resources to the primary care physician or nurse practitioner that might not be comfortable treating clients with a severe mental illness. So they might work to develop mental health treatment protocols, to develop mental health screenings within primary care, and to provide education for staff and for patients. And collaborative practice models have proven to improve both mental and physical health outcomes. Another evidence-based recommendation from the literature to address clients that don't have insurance and have a mental illness are federally qualified healthcare centers. These are community-based organizations that provide comprehensive primary and preventive care to low-income, uninsured, or underinsured people. They receive federal grants and are eligible for monies from HRSA. And one such group that has been mentioned a lot in the literature is the Family Practice and Counseling Network in Philadelphia. There have been lots of articles, and they've conducted a lot of studies. They've been very successful in the work they have done. And one thing recently they published a study about is we know that getting a client into treatment for a mental health issue can take a long time. There's often waiting lists. but they have managed to cut their waiting list by 2 weeks just by having a clinical social worker within the primary care setting. The clinic I work at is a federally qualified health care center. So the rest of the presentation, I'll be talking about our clinic and what we do to care for the clients without insurance. So a little history about our clinic. This is a clinic, it's under the College of Nursing at ETSU. It is a nurse-managed clinic. It started in the early 1990s, and it was just 2 little rooms, 2 dingy rooms, I should say, in the basement of the Salvation Army. It was a really creepy place. And it was opened up just to see homeless clients. That we provided primary care to the homeless clients, and we also had a psychiatric nurse practitioner working within this setting that provided psychiatric care. So already that was a great benefit because homeless clients often they're very hard for them to keep traditional appointments at traditional mental health settings. So at this clinic, they could get both their hypertension taken care of, they could get their bipolar taken care of. And if the family nurse practitioner saw someone was managing their hypertension and found that they seemed depressed, well, there was an on-site person, that the Psych NP, that could talk to them that same day. So the literature recommends that clients should receive both primary care and mental health care under one roof, so we were able to do this early on. And in order to reach some of our clients with severe mental illness, we had to venture out into the homeless camps. And so right along where Wendy's, all of those new Pals, all along that area, there used to be trees, tons of trees, and there were homeless camps in these trees. And I'm talking big established camps, like 30 people at a time. And what we did is we actually took a little card table, this is one of our nurses, and set up a clinic out there. We took their blood pressures, we took them socks and food items to kind of gain their trust. It was a real hard population to get their trust. And so we took treatment to them. I can't tell you how many long-acting antipsychotic injections I've given out in the woods. Don't know if OSHA would be happy with me, but we had to do what we had to do to take care of these clients. So when we were in the Salvation Army, we did a lot of outreach to homeless camps. And still today, I think a lot of people, if you're not used to working with homeless, you would be surprised right here in Johnson City, the number of established camps that are here just a couple minutes away. And even in North Johnson City, several camps where our homeless clients are staying. So at this clinic, at the Salvation Army, we started realizing our numbers started to grow. And so we were able, Mountain States very kindly gave us this building on Fairview Avenue. It cost $1 a month. We love them for giving us this building. So we moved from the Salvation Army to this building on Fairview. And we thought we'd really moved uptown. Now, if you could see it, we're still in this building. So anyways, we continued to do the same thing. We had psychiatric care, we had primary care, all under the same roof. They could access both forms of treatment all under the same roof. This clinic started to grow, so we moved to Myrtle Avenue. I don't have a picture of that clinic. That clinic started to move. We got a $2 million grant, and we built the Johnson City Community Health Center, which is behind Woodridge, if you don't know. And this is a big, fancy clinic. This clinic is a FQHC, a federally qualified healthcare center. So we provide care to those who don't have insurance. We provide care to those that are underinsured. We provide care to migrant populations. We have people that choose to come to us that have private insurance. And for those who might be living in poverty, we do a sliding scale fee. We kept our clinic on Fairview, and this is called the Johnson City Day Center. This is where our homeless clinics come. At the Day Center, this is a place where our clients with mental illness can hang out all day long. Many clients with mental illness that they don't have access to treatment, they're acutely ill. If they're staying in a shelter, a lot of times the shelters don't want them in because of their acuity. If they're walking around psychotic, screaming, they don't want them around, so they're kicked out. If they are able to stay at the shelter, all shelter residents in Johnson City have to leave the shelter at 8 o'clock in the morning in order to encourage them to find jobs. And that's great, I'm all for that, but some of our clients with severe schizophrenia aren't able to work, so they have no place to go. So this is a place that they can come, they can stay all day, they can watch movies, they can wash their clothes, they can take showers, they can eat food, and more importantly, they can get primary care and they can get psychiatric care. This is where I practice 2 days a week. And so again, you're getting primary care, psychiatric care under the same roof. The homeless that come and hang out in our waiting room, we interact with them. We ask them about other homeless camps. They take us into other homeless camps, so we're really able to identify a lot of clients out there who maybe are homeless, uninsured, and need access to treatment. And still, we still go out to camps, we go to homes. I've even gone to a bar to pull a client out to give them injection. We do a lot of outreach, stuff I guess I shouldn't do, but we do. We even go to the jail to look for clients that have mental health issues. The Washington County Detention Center, we've worked with them for many years. They let us go in to see clients that don't have insurance so we could start treatment in the jail. So when they get out, they can come to our clinic and continue their mental health treatment. So the model we use at both of these places, the Johnson City Community Health Center and the Day Center, so the Day Center here, mostly homeless we see, and this could be anyone, but it's mostly uninsured or underinsured. So this is our model, and I think, not to sound braggy like Donald Trump, but I think what we do at our clinic, we do pretty well. Our patient can access a multitude of services. So they have a family nurse practitioner, and I should have put up here, and forgive me, but we have many physicians that are so wonderful that volunteer their time at our clinic. Dr. Schmidt has volunteered to take care of our clients with GI issues for over 15 years. Dr. Stewart from ETSU College of Medicine, we are so appreciative of them. Any psychiatrist that would ever want to come, we'd welcome you. But we're just so thankful for the physicians that come and volunteer. So our patients, they can see a family nurse practitioner if the nurse practitioner is having difficulties managing their diabetes. They can refer them to Dr. Stewart, who will see them for their diabetes. So they can get family nurse practitioner care, primary care. They can get care from the PMHNP, the psychiatric nurse practitioner. They can do the psych evals, they can start medications, order any lab test, and provide counseling. We also have psychology at our clinic. We have psychology doctorate students who come, and they are great. They come, we have about 3 each semester that come 2 days a week to provide counseling. And we have social workers there, and this is great because clients without insurance, they have great difficulties accessing services. So we have both a BS prepared social worker and we have a master's in social work. They also can work with the client to help get them connected to treatment, to find ways to help them be able to afford their medication. And something really unique that we have that the literature recommends, they talk about collaborative practice models, and they really recommend having a person like this at an integrated site, and it's a BCPP. So does anybody know what that is? It's a board-certified psychiatric pharmacist. So at our clinic, we have Sarah Melton from the College of Pharmacy. She's amazing. She is qualified to what a board-certified psychiatric pharmacist can do. They can do a psych eval on a client. They can start medication on the client and continue to see them. What Sarah usually does at our clinic, if an F&P is seeing a client and they seem to have a pretty serious mental illness, if the F&P may call the Psych NP. If they're unavailable, they'll call Dr. Melton, the BCPP, and she will see the client, start them on medication, or she may just work with the F&P and recommend medications that can be given to the client. And then one very important piece to all of this is the case managers. We have case management, and this is particularly important for our homeless clients, for our clients living in poverty. So the pictures I showed you of the gentleman with the messy house, the case manager will go in and help these clients be able to maintain housing. They'll make weekly visits. They've been known to kind of do things maybe they shouldn't, but help get the house cleaned, take them food. But they meet with them every week to be sure they have money to pay their electric bill, to help them if they're able to go to voc rehab, to help them get their GED, to help them. We've had 2 clients enroll at ETSU recently. So that case management is an integral part of our care at our clinics. They work with our clients on a weekly basis. And so the patient can benefit from all these people under one roof. And one of the biggest barriers that clients that don't have insurance have are paying for medications. I see this happen a lot. We get clients from inpatient settings. It could be from out of state. It could be here forever. And they're released from an inpatient hospital with medications that would cost them $1,500 a month that they paid for. So that is a big barrier. And I see some facilities, they will take them off Fanapt and start them on Thorazine because that's cheaper. And we don't do that. We don't have to do that. We're very lucky. We use the ETSU Charitable Pharmacy. That's housed at the Johnson City Community Health Center. That is for people that don't have health insurance. They can go to this pharmacy to get their medications filled. Now, it sometimes varies in what they have, but many times they have some of the high-dollar antipsychotics like Abilify, or they've had genetic Seroquel. They've had Zyprexa. It just depends, but they have most, all of the antidepressants, generally speaking, so they're a great resource. But our biggest resource, and it takes a lot of time, but I say this is what we do when we have a client that's on a high-dollar atypical antipsychotic. Instead of taking them off of it and putting them on a cheaper typical, we will work to get prescription-assisted medications from them. And we use needymeds.org. This is fabulous. I can get Resperdal Consta for my clients free. The only med I can't get through these organizations is Vivitrol. I wish I could. That would be great. But most of the psych meds, it's really surprising what we can get free for our clients for patient assistant programs. Jensen has a great prescription assistance program, like I mentioned, Resperdal Consta, all of that I can get free. I've listed another resource, but generally you can check needymeds.org. You go to this website, you can type in the drug to see where you can get it free or at a cheaper cost, or go to the drug company that makes the drug and find out if they offer these medications to clients without insurance, because I'm always surprised at the ones who do. Now, this process takes a great deal of time. Unfortunately, it's not been uncommon for me to spend a couple hours on the phone trying to get free medications for my clients that don't have insurance. But it can be done with time and dedication. And again, I can't emphasize it, needymeds.org has been great. They're just wonderful with our clients. Okay, I will stop there and see if anyone has any questions. Yes?